please explain how agenda setting works in CBT?
The agenda for today will be that we will talk about your homework. Okay, so we'll see your homework. Then we will see how was your week last week. And then what will be the goal of today's session? Hello. This session today is specially designed for depression. This session is useful if you are a student of psychology, if you are a beginner and a practitioner psychologist. This session is also useful if you are a researcher whose background is not pure psychology and they want to learn more about depression. If you are a person who himself or herself or any of your family member has been suffering with depression, even then this session is going to be quite useful. Feel free to comment on this session, please. Today, to make it more realistic and useful, we have a practitioner psychologist, Ms. Aksa, with us. She has some questions which are coming directly from her clinical practice and experience. And based on her work in the clinic, she has those questions designed for the betterment and utilization of everyone. So let's start. Hello, Aksa. How are you doing?
Alhamdulillah. Thank you so much, sir, for giving me this opportunity.
You're
I
welcome.
would like to ask about depression. Would you please comment on what is depression and what are the misconceptions about depression? Because it's more highly prevalent disorder right now in country, worldwide it is. So would you please share your concerns about this?
Okay. So depression is something that has its own statistical presence in our country. As you said, it's also prevalent globally with a very large percentage. I will not go into the clinical details of clinical depression, the details about in terms of the medical model, because that's the field which I think should be left best to psychiatrists and the medical specialists. Nevertheless, it clearly relates to us. And the first thing that I want to highlight here is that the term depression is most commonly used, most widely misunderstood, and also sometimes I would say overdiagnosed. When I say overdiagnosed, that means that many medical professionals or psychologists or social workers, they can label people, they can under-label them or over-label them with depression. Why? Because the symptoms or comorbidity is so vast that it's very easy to mix it up. What I'm going to talk about today are those cases where the depression has been diagnosed either through a DSM criteria or it has been diagnosed by the clinical experience of the clinician. How depression is being treated in a psychological setting is very important. First of all, I would like to say that the requirement of depression treatment to be done through a pharmacological medical model or through a counseling or psychotherapy model is something that has to be decided through a very collaborative effort. It is very important that the diagnostic process should be done ethically and professionally in a very correct way. Assuming that it has been done, a person has been diagnosed with mild depression, let me also add that if there is severity of depression is very high, where it is associated with suicidal ideations or thoughts or attempts, then it has a different protocol. And this video is not the right platform for that kind of a treatment. So we will be talking more about the mild or moderate depression. So assuming that it has come to a place where psychotherapy has been it has come to the client has come to our clinic, and we see that it's a treatment of depression that we need to do, then the model that we use on CBT will be implemented. So why we use CBT is a very important question that I think will explain in itself that why we want to use it. Before we do that, I will also like to add that the patient who comes with depression needs, in our part of the world where we are right now, and I'm sure in many other parts of the world, that there is a lot of misconception that needs to be clarified to the client about depression. There is so much sense of helplessness, or as if it is something which is making a person dysfunctional, probably permanently in their opinion, and that needs to be reviewed with the client as well. So we normally use CBT for the treatment of depression.
Yeah. Okay. I have another question, just like you mentioned about CBT. Mm-hmm. Would you please explain why CBT is being used as a treatment for depression?
Okay. Cognitive behavior therapy, when we talk about cognitive behavior therapy, we have to know that there is a major chunk of this which is behavior therapy. This is how when I explain the treatment of depression through CBT, then in that I would say that the B part in this CBT model is very big. Why? One of the reasons that people suffer from depression, or you can say the chemical reason of that in a layman's term, is that we have some deficiencies of neurotransmitters and hormones. For example, when doctors, they treat depression, they give the SSRIs. The SSRIs are what? They are the medicines which try to maintain the serotonin level in a person's body. So SSRI means the selective serotonin reuptake inhibitor. So when we say reuptake inhibitor, it means that the reuptake has been inhibited so that the level of serotonin is not allowed to deplete. Why? Because for some reason that serotonin is not being made. Now, what function the SSRIs will do? Antidepressant, that means SSRIs are antidepressants in the nutshell. What they do is something that we would like to achieve through therapy. Not that a replacement of medicine, not at all. But people who have depression, for example, and I'll give you a very crude example. A person who's been depressed, who comes and says, I always feel like sitting on a sofa, or I'm always lying in my bed, I don't feel energy to go and move, I just want to be sitting there. I have isolate myself, or I have no energy. So there is a word energy that comes in, or I don't want to do something. Now, even for these people, they have to drink water from a refrigerator. they would want somebody to do it for them.
Mhm.
Even if they have to pick up a remote control which is lying farther away from sofa, they may not find themselves ready enough or energetic enough to and grab it. So what we mean to say here is that a lot of depression that is existing in our model of society is coming from lack of activity as well. And this is the biological model that I really want to refer to. A lot of clients, they are coming to us because of their lifestyle. They have indulged themselves into a routine that is itself depressive. I'm not saying that their body functions are absolutely normal or they don't have any problem and it's only because of the routine that they are depressed. No, but the routine is actually, instead of supporting and acting like an antidepressant, is rather contributing for them to become more depressed. So it could be their diet, it could be their sleep, especially if their sleep hygiene is not there, or they are sleeping very late, waking up very late or early, not getting enough sleep. Water intake is very less. So this is super important that as a clinician, once you have a person who comes with depression, you need to understand that what kind of physical activity level they have. A very big question comes in that is it because of the physical activity that they are depressed, or it is because they are depressed and that's why they don't have a physical activity, which is an absolutely correct argument, and we don't deny that. But what example I want to bring here is that how CBT helps is that when a person picks up a phone or get referred to a psychologist and they come for the session, you will find out in your practice that those people for the session are pretty motivated to come, most of them. We don't have much referrals here. We come from GPs or doctors. Therefore, more of the clients are coming with their own volunteer. They volunteer to come. When they come, CBT, coming back to your question, why it is helpful? Because CBT is a collaborative approach. In CBT, you set an agenda for the session. You create a framework of the session. There is a time, 45, 50 minutes or 1 hour maximum. And in that time frame, you have to do as per your agenda. The agenda could be, if it is your second or third session, the homework checking of the last session, which is filling up some thought sheets, thought records, It is then at setting the goals for today's session. That's the second part of the CBT session. And once you set the goals and you have done the homework part, then you go through the process, maybe through motivational interviewing or through other Socratic questioning or how the week went on. So that's different type of counseling or therapeutic technique that we use within the CBT model, that how we communicate. We will have a different video for that how will we actually communicate to the client. Will we be talking? Will we be listening? How much will be listening? How much will be talking? And even if we are listening, what is reflective listening? What is active listening? So definitely that makes CBT very powerful and wholesome. However, coming back to this, that while the CBT is collaborative, you make your client do some work, it within itself is a therapeutic experience. Like they know we went to the session, now we have been told to do a certain amount of homework every day. And the homework is not very analytical and complex. No, you just have to write down how you feel that very day in blocks of 2 hours or 1 hour or 3 hours. What is really important in CBT, as you asked that why, because the depression is a triage caused by a triage of thoughts, feelings, and emotions. So you have a certain thought that translates into a certain feeling, and that feeling translates into an emotion. Now that emotion is then loops back to the thought, and that it maintains your depression or anxiety or whatever you experience. That's the triage that we follow in a normal way. What CBT does is that we allow the client to tell us their thoughts. Then we ask them that this thought creates what type of feelings in you. And then these feelings create what type of behavior based on the emotions that you feel. So, give you an example. A person is sitting in a cafe, in their office, or in their university, and one of a good, very, very good friend, they pass by, or he or she passes by, and apparently they have looked at this person, but even didn't wave or say hello, and they pass by. So an event has happened. This event would trigger a thought in the person sitting in that chair, that why this person has not said hi to me, has not greeted me, why there was no warmth, why there was no contact. And now, based on various factors, some types of feelings will come out. Is there something wrong?
No.
Is that I'm not good enough? Is that he or she thinks something about themselves? What? So it could be anything. And then that thought will trigger emotions. When I say emotions, it means the trigger of hormones and neurotransmitters. They secrete. They are secreted. When they are secreted, they now create a loop of thoughts again and maintain them. So we have a complete loop of dysfunctional thought patterns which follow our life sometimes. What psychotherapy allows you is that once you talk to a therapist and you say, all right, I found somebody, they did this to me. So then you say, that must be very disturbing. In your opinion, what could be the reasons that they did not say hello to you? And then they can review or have a moment to reflect. So not that they will actually believe in what they are saying, but you give them an option to review that in your opinion, what all could be conditions where a person may not say hello to another person. So they may say, maybe they are rude, maybe they are this, maybe they are that, maybe I'm not good enough, maybe da. And then maybe they come up with this, that, maybe they were in their own thoughts. Maybe they even didn't see us. So then you ask them, all right, that means that there is a possibility that something is not what we are thinking. Something is there which could be different. What I mean to say is that as a psychotherapist in CBT, when we ask people to record their thoughts or their feelings, we want them to validate them. So when they go back, for example, a person is depressed, so you ask them, you have to write down 2 hours, 10 to 12, what did you do? How was your mood? 4 to 6, so every 2 hours. What is really interesting is that human brain is designed in such a way that it generally remembers more the negativity, the sadness part, the bad part. Maybe it's part of our evolution. That the happiness part, even if it is long enough, we think it is not long enough. The bad part, even if it is short enough, we remember it for the rest of our life. Because probably we want to avoid it. That's our system, how it makes. Now, what thought sheet does is that a person is feeling depressed. He or she is thinking, that my mother-in-law has done this, my husband has done this, my son has done that, and they are maintaining those thoughts. and the emotions keep fueling the thoughts, the emotions, the heartbeat, the lack of energy, whatever. So they tend to believe that they are super depressed. If you ask them in your first day that on a scale of 1 to 10, how much depressed you feel, they may say 5 or 4. But once you ask them a thought sheet, divided into blocks, 2 hours, 2 hours, 2 hours, 2 hours, you will be surprised as a clinician, and they themselves will be, that actually in the whole day, they might not be as depressed as they are thinking about it. They say, okay, I woke up, I had my breakfast, I saw the news channel, mood is 8 out of 10. Okay. Next, I got a call from a friend, we had a chat, she talked about something very, very painful, 4 out of 10. After I dropped the call, I was not feeling well. I just talked to my mom. One of my cousins lives abroad. I talked to them, and mood 7 out of 10. When you take out the whole average, you will find it that the actual whole of that is not equal to what they actually feel. This in itself is very reassuring for a depressed person that, no, I need to review how I feel. Mm-hmm. The last thing that I want to talk about, especially in this part of CBT, is that we would like our clients to get on their feet. We have to jumpstart them. And psychotherapy, whether it's online, whether it's in the clinic, is an opportunity for them to give them homework, either to go for a walk or to get into some physical activity. And they have to be psychoeducated that how this physical activity will increase or improve their mood hormones, the mood stabilizing hormones, or the serotonin levels. And you will see that although it's difficult, your client can come back and say, no, we could not walk. That's fine. As long as they are aware that this was something that. One thing more I want to highlight, that depressed people also should learn the definition of accountability. They need to be more accountable of their own action. One of the reasons that they feel more depressed is because they think they're helpless and the rest of the world is doing to them. They don't feel themselves accountable and responsible for the actions. So they don't feel themselves accountable or responsible for their actions. So we, through that, make them that no, you still are accountable and responsible. Whatever you feel, if you're not walking, if you're not doing your homework, then this is not the world which has done to you. This is something that you need to do yourself. But as a clinician, you need to be more supportive. I want to tell you one more thing here, that when they come and they tell you we didn't do it, we didn't do the homework, or they turn up a bit late for the session, or they miss their commitment, your response to them has to be different than the rest of the world. So that's why a clinician's own emotional limitations should not come in the way. The unconditional positive regard. So this is a model that they have available, that this is how you react to others' mistakes. That you made a mistake, another person said, all right, it's fine, no problem. Let's find out how can we do it better next time. So that's something that's also very therapeutic in CBT. So putting them into action is very important. That's what I really wanted to say. Yeah.
Okay. So you have so beautifully explained how CBT works in depression and how it works for the clients. You mentioned about agenda setting in CBT. Could you please explain how agenda setting works in CBT?
Yeah. Okay. The agenda setting is something that is as important for the client as it is important for the clinician. Because the client who is coming for CBT, he is suffering, whether it's coming for depression or any other anxiety disorders, they are suffering because their life pattern, for many reasons, but one of them is that they need help. We would like clinicians, just like a lesson plan, they need to be ready that what they are going to do in the session. What CBT does is, or CBT, why I like this approach, because it is quantifiable. It's measurable. It's measurable not only for the client, but it's measurable for the clinician also. That how much, if I have to measure a clinician's performance in a CBT session as a supervisor, I have clear lines that how the session has been conducted, how the time division has been done, how the therapeutic alliance, emotional connection, and all that has been established while maintaining in a framework. Because if you don't have a framework, then people can come, talk, laugh, or cry, feel good about it, and will not learn anything as patients. A CBT practitioner has a complete agenda. So what is the basic thing of agenda? When we say agenda setting, we use this word. Okay, the agenda for today will be that we will talk about your homework. Okay, so we'll see your homework. Then we will see how was your week last week. And then what will be the goal of today's session? Remember, when a client comes, well, first time they have a strategic goal. A person can come with a goal of that I feel depressed and I want to be more energetic. That's a strategic goal. Strategic means it's a goal that they want to have in overall 5-6 sessions of therapy. But once there is a session coming in, a session has a short-term or a tactical goal also. A tactical goal is basically a step towards your strategic goal. But it is based on how the homework went, how the last week went, how their behavior or whatever in the last session they discussed, how will their communication strategy will change, how their behaviors, how their thoughts, whatever was happening between the clinician and them, it has been applied and how it has created a result. So that all discussion will now come in the goals of today's session. That based on our last session, what are the goals? So the goal could be, okay, the goal is that let's suppose a client has come who has been feeling depressed because of a relationship with their husband or wife. And they say that today my goal will be that how can I handle the sudden mood tantrums or aggressive pattern of my spouse, which he or she reflects on children. Okay, for example, that's one of the goal, because that could be contributing to the whole spectrum. So the goal has to be there. You need to ask, because what clinician, the mistake they make, they have case notes. In the last session, something big happened in the client's life, and the client had gone. The clinician opens the notes and they say, last time she had an accident on the road, something happened, or she had this and that. Let's see. You should talk about it in case that comes up, or at least you ask. But don't assume that the client is still stuck over there. No, the client might have had a totally different set of problems today in the session. And trust me, they will not talk about it. They will just come and they expect that you drive the session. And that's one of the biggest mistakes by clinicians, that they start to drive the session based on the case notes, based on the strategic goal. So how was your week? Okay, this and that. No, you need to ask, what will be your goal of session today? Trigger a thought. All right, I'm giving a chance to talk about what I'm here for. If you don't ask, maybe that will never come. That moment, because one trap here is that when people sometimes ask before the homework, you've not checked the homework, you say, okay, let's talk about your last week. How was it? The moment they will start to talk about it, you may find that you get so much distracted by that discussion that the whole session may finish, the homework is gone, the complete agenda is gone, nothing happened. You didn't achieve anything. Maybe a bit, but not in a framework. So the clinician will not be able to deliver what they need to deliver to the client, because we want to deliver. We want to have quantifiable parameters of performance or improvement that the client faces. So that's why agenda, homework, last week, goals of session. So these are the three things. And in the end, then you can sometimes ask for a feedback, that how was the session? Did you feel that you were able to answer questions? Okay, reassurance, and that's how we conclude. There's a complete different video that we will take, how exactly a CBT session will take place, but this is more or less similar that we do it in depression. So that's how the agenda setting is so important.
Okay. I have a last question, that why do we assign home tasks like homework to our clients?
Okay. Homework, as I mentioned earlier, is very important because we would like to have a tool available where we would see that how compliant the client is. It gives them an opportunity to do something. For some client, it's motivating. They take something from, okay, I have a homework, because for a client, the clinician is a very powerful relationship, so that's why it's super important that homework is given. That one, it's an activity. The activity itself is therapeutic. It will produce serotonin. It will produce those hormones. Then as I mentioned, it will create a more realistic measure of their moods. Okay. It will also make them more disciplined in a way, because many clients who are suffering with depression otherwise might have a lack of discipline in their life, which could be okay. It's their own choice of life, but if it is contributing towards their disease, then it needs to be corrected in some way. Then for clinician, the homework is that once you get the homework, you check it, and then you ask about it, that how did you feel about this homework? What do you feel different about it? Then that's another discussion that we can do. But a clinician is also now involved with the client, that how the week was. So homework has a very powerful implication in CBT. We would like but make sure that
behavior activation.
Yes, the behavior activation is same, that once they do something, their behavior is activated. It creates that the hormonal changes in them, and also motivates them. They also find a result. They have something to look forward to.
Thank you so much, sir.
Thank you very much. So just to conclude now, we have talked about in this session that what could be the misconceptions about depression. I'm aware that this is a non-exhaustive list of things, that depression is such a vast topic. But we were talking about those aspects of depression where in a CBT setting or in a psychotherapy session, how can we handle this problem with our clients? How in this particular setting depression can be treated for our clients? What are the challenges to clinicians? What are the benefits of CBT? How CBT can help, and how the structure of CBT why the structure of CBT is so important in treatment of depression, and what's the importance of homework and activity and physical. My last few cents are that although physical activity is something which is I'm aware that many clients resist, but the therapeutic alliance between psychologist and client must be used to jumpstart them into action, at least in the normal activity of going out for a walk, or at least moving on their feet, because that's something that can at least help many people in reducing their level of depression. Thank you very much.